formal introductions and so on. So welcome all, and a warm welcome to our audience for this, our third session in the seminar series on transcontinental, colloquium, reflections on borders in the time of COVID-19, which is organized by Moritz Mihards from the British University in Cairo and myself, Kasper Andersen. I'm from the University of Aarhus in Denmark. So this is, as I said, is our third talk. In our first talk, we had Paul Nugent inform us on borders and COVID in African contexts. And 2 weeks ago, I think it was maybe 3 weeks ago now, it was Professor Brian Beck who talked about border regimes in Russia and in the Soviet and the period after the Soviet as well. And today, it's a pleasure to welcome Professor Andrew Lakoff from the University of Southern California. And yeah, a warm welcome to you, Andrew. Just a brief introduction. Andrew is a professor of sociology. He has a BA in history and is trained as an anthropologist of science and of medicine, and has conducted research in several localities around the world. And his areas of interest include globalization processes, the history of the human sciences, contemporary social theory, and risk society. So I think really the COVID is very central to several of these research interests. And among Andrew's many publications, I would highlight here his first book on pharmaceutical reason, knowledge and value in global psychiatry. And there was also a very interesting edited volume around some of these issues on global pharmaceuticals, ethics, markets and practices that came out in 2006. And then his most recent book is, I think, very timely, titled Unprepared, Global Health in a Time of Emergency from 2017. And much of this work really concerns some of the issues that we have talked about and that are central to this seminar, namely about borders, about futures, about uncertainties, about things that travel and things that do not travel so well. So we're very exciting also to get this perspective into our discussion. And the title for Andrew's talk today is called Preparedness Indicators and the Global Extension of Health Security. So Andrew, thank you very much for coming here today.
Well, thank you very much for the invitation. I think I'm gonna do a little work with Moritz to set up my slides, and then I can launch into things.
Exactly. I'm going to make you the I'm going to make you presenter now. If I press the right button, there we go. Okay. And now you should be able to share your slides.
All right, I'm going to give it a shot.
Yeah, now you actually shared the, yeah.
How does that look? Okay, miraculous. Well, thanks for that introduction, Kasper, and thanks to both Kasper and Moritz for this invitation to think about borders in the time of COVID-19. We were just having a chat before the session started about comparing the politics of pandemic response across our different settings, and it's always really fascinating to talk with folks, with colleagues in other places. And so I think my hope is to spend about half an hour presenting some of my work, trying to open up a conversation, but also to spend most of the time in a discussion with all of you. I'll just begin by talking a little bit about the background to the presentation. This work began, as Kasper said, with a book that came out a couple of years ago called Unprepared: Global Health in a Time of Emergency. And the work builds on that, but really most of what I'm going to present is research that I did before COVID-19. And so one of the things I'm really interested to think through in this context is what the implications of this pandemic are for this form of critical analysis of global health that I was already engaged in. And I'm still trying to think through how to understand the present as it's unfolding. Let me start in the context of borders by mentioning just one prominent discussion around the impact of COVID-19, which is a suggestion that the very political category of the global has proven surprisingly evanescent, surprisingly weak, as a significant political category, in that distinctive governmental responses have been critical either to success or lack of success, mainly at the nation state level, and that global organizations, whether it's the World Health Organization or philanthropies like the Gates Foundation and Médecins Sans Frontières, have proven fairly marginal. And I want to step back a little bit from this particular conversation and return to it later, but just by contextualizing the very notion of a form of global health security. Where does it come from? What knowledge forms and tools does it depend on? How does it seek to intervene in a global space? And I'm going to focus, based on my background in science and technology studies, on a fairly mundane technical practice, and then hopefully step back and contextualize it more in terms of the politics of this practice. But I'm going to focus on the practice of assessment, of metrics for gauging how prepared for a global health emergency a given country is. Let me begin with what I think of as a kind of ironic slide. So this is an image from a report that came out in 2019 called the Global Health Security Index. And this report rated 195 nation states on multiple metrics of their preparedness for a global health emergency. And you'll note on the left-hand side, the overall score, after measuring, dozens of different elements of the preparedness of each country, the United States and the United Kingdom come in first and second. And it's remarkable because, of course, currently the United States, where I am, and Great Britain, I think stand as poster children for a failure of collective response to the emergency that actually unfolded. So I think this is a really interesting piece of data that people who studied and tried to implement global health security measures thought that the US was extremely well prepared. And you'll see way down the list, I don't have the entire chart, but you'll see South Korea number 9 and other countries that are seen to have had actually a fairly successful response, Germany, Taiwan, and so on, Singapore, much further down the list. So it's an interesting puzzle. And so I want to unpack what was in this Global Health Security Index, where it came from, and what it was missing, what we now know was missing based on the actual responses each nation has had to this pandemic. Again, I'll talk about metrics that are designed to make capacities comparable across different countries. What kinds of metrics are used? Where do they come from? What was the impetus for putting them into place? And I'll talk in particular about the concept of core capacities in preparedness and response. Let me start just with the very notion of global health security and what that means. Oh, I think Casper, can you, and Moritz, can you still see my slides? Can you all still see my slides?
Yeah, we did. The Save for Future slide.
A Save for Future. Okay, sorry. On my screen, things went a little haywire, but now it's back to normal. I promise not to touch anything again. Okay, so the very project of creating a form of global health security really was invented in the late 1990s and early 2000s, and it was announced in this 2007 World Health Report from the World Health Organization. And it's important to underline that this form of security approaches a distinctive kind of health threat, which is known as the public health emergency of international concern. And by this term, a number of different kinds of incidents were included. It could include the outbreak of a novel and dangerous pathogen like Ebola or coronavirus, but it could also include a biological attack, even an environmental accident. But what's key to the category is that it should be novel, unpredictable, and potentially catastrophic at a global scale. The quote here that comes from the report points to the two basic functions that are at the heart of a global health security apparatus, alert and response. And the quote also indicates the spatial problem that's at stake in the operation of this apparatus. So global health security hinges on the functioning of national systems. This what I'm calling an apparatus of global health security faces at least two major challenges, which we can term one of jurisdiction and the other of jurisdiction. So first, its object of interest is something that has not yet occurred and may never occur. In other words, it has to operate in the present on an object, a future emergency that cannot yet be grasped. And secondly, in terms of jurisdiction, it strives to be global, but it requires the cooperation and support of national and local public health agencies. So there's a disjuncture between the locus of responsibility and the locus of sovereignty. And even before COVID-19, if you study the last decade of global health emergencies and near emergencies, from bird flu to swine flu to Ebola to Zika, you can see that responses to these events have been characterized by tensions in addressing these two obstacles. So given this orientation to the future, the question that global health security must continually ask itself is, are we prepared for the next emergency? And the answer, typically, whether this comes from responses to an actual event or to a simulated event, to an exercise, is inevitably no, we're not prepared. And that's why I titled my book Unprepared. The book isn't a diagnosis that we aren't as well prepared as we should be, but rather it's a characterization of this style of reasoning and affective mode, which is we must continually prepare for something that may come or may not come in the future. The next question is, how can we become more prepared? And I have here kind of three elements of what I would call a preparedness kit. And these elements go together in any kind of assessment of a state or condition of preparedness. A checklist of what emergency actions will be necessary in the future, a technique or practice for enacting or playing out a potential event so that you can test the efficacy of your capacities, and then a process of assessment and critical self-rectification in the aftermath of this practice. Now, there's a longer history to this kit, to this apparatus for critical self-rectification and for reflection on one's national condition of preparedness. I don't have time to go into it in detail, and I'd of course be glad to talk about it more. I've been working on a book with Stephen Collier that's going to come out next year on this genealogy, which goes back to the 1930s and into the Cold War in the US, on that really originates with preparedness for a nuclear attack and the development of checklists, of simulation practices, of modes of assessment for dealing with the possibility of this unprecedented but catastrophic event. And gradually over the course of the 1960s and onward, this mode of preparedness expanded from the world of nuclear war planning into other fields, from natural disasters to potential terrorist attacks, to environmental accidents, and on into pandemics by the late 1990s, early 2000s. But if you look at whether it's plans from the 1960s or more recent plans, such as this critical infrastructure protection plan that I'm citing here from 2013, you'll see a similar set of resources, of checklists, of planning capacities that that a country is supposed to have put in place in anticipation of an event that could disrupt the vital systems that ensure the continual functioning of economy and society. And so that's the basic structure of this form of rationality that's at play again in global health security. I guess just to give you a little bit of a taste of the theoretical conceptual perspective that I'm coming from, I've already alluded to this concept of apparatus, which I find useful for understanding both the contingency of this initial assembly of these elements and then its ongoing staying power, as well as its potential extension into new domains. So global health security, if we look back at the schema that I'm describing, this kit, it's formed as a specific response to an historical problem, quoting Rabineau here, who's really alluding to Foucault, in a particular setting, but then it has the capacity under certain circumstances to become generalized. So this bundle of elements, the checklist, the exercise or the simulation, and then the post hoc practice of assessment is a kind of engine of the specific apparatus that I'm trying to describe here. So let me now turn to the appearance beginning in the late 1980s and really consolidating in the 1990s and 2000s of the problematic of emerging infectious disease as an object or target for this apparatus. In this period, mainly beginning in the US, the category of emerging infections was invented to describe the appearance of novel, untreatable, and potentially catastrophic diseases. Importantly, in the wake of the AIDS pandemic, but there were other diseases as well that were seen as exemplars: Ebola, Marburg virus, later SARS and avian flu, and others. And let me just make a few points about this category of emerging disease, which became taken for granted not long after. First of all, from the perspective of those who are experts in emerging disease, the arrival of these diseases is bound up with globalization, seen as a source of vulnerability. So these events travel rapidly along global circuits. The possibility of a disease outbreak of one of these novel infections, it can be seen as a modernization risk in Beck's terms. That is, urbanization, environmental degradation, and new technologies of rapid global circulation had rendered populations newly susceptible to these outbreaks. Secondly, these outbreaks or diseases cannot be prevented. That is, they're going to continue to emerge over time. And the only way to protect against them is to rapidly detect them and quickly contain them. And of course, that's what did not happen in the case of coronavirus or COVID-19. Thirdly, these diseases are seen to emerge elsewhere, speaking from the perspective of the global north, but they are threats to us, again, speaking from the perspective of wealthy countries in the West. So therefore, not just a national, but a global form of mitigating this risk is necessary, thus global health security. The SARS scare of 2002 was understood in these terms. The global population had been made vulnerable by the lack of detection capacity and response capacity in a single country, in this case, China. And over the following decade, after 2002, 2003, a generally agreed upon diagnosis and prescription for how to deal with these threats consolidated. First of all, we, as a global community, lack the surveillance capacity to detect emerging diseases in time to contain them. And secondly, a critical problem is that nation states, again, in the case of SARS, we would take China. We might take the case of China again in thinking about COVID-19. Nation states are often hesitant to report outbreaks and to allow international experts into the countries to monitor them. And there were other cases of this in the 1990s. In India, there was a case of plague, in Venezuela, a case of cholera, in which it was difficult for global health authorities to get a read on what was unfolding, because national populations did not want the stigma of having an outbreak and the threat to economy and trade that would imply. So to address these problems, global health reformers proposed a major revision of the international health regulations as a way to generate novel tools for surveillance and response around the globe. So I'll say a word about the international health regulations, which were agreed to by the member states of the World Health Organization in 2005. That is, a revised version of them were. The system itself dates from the 19th century, from 1851, and it's designed to ensure state sovereignty over public health response to an outbreak, while at the same time regulating nation-state action in order to minimize economic disruption and to ensure that international authorities can monitor and minimize circulation of the disease. In other words, it tries to make sure that nation-states don't enact overly restricted trade regulations in response to the outbreak of a disease, regulations that could lead to economic disruption. And this dates to a 19th century era of global trade. The current revised international health regulations envision a coordinative and supportive role for the World Health Organization, one that's importantly dependent on the actions of national health authorities. So it provides, that is, the World Health Organization would provide administrative and technical protocols that enable a liberal form of government to manage the circulation of pathogens as a collaboration between multilateral and national authorities. But this system lacks legal enforcement mechanisms. It's an international treaty, but of course, national laws typically will overwhelm, and national responses and regulations will overwhelm the norms of the treaty. And it does not have adequate financial resources to achieve its goal. This revision in 2005 tried to address some of these problems. It expanded the list of events that could constitute a health emergency. The prior list had been 19th century scourges like yellow fever, cholera, and plague. The revision defined the actions that the World Health Organization was supposed to take in order to coordinate emergency response, as well as the role of nation-state partners. And then this third bullet is the one that I'm most interested here in this talk, and this as part of the revision of the international health regulations. And this is a revision that obliged all member states to develop what were called the core capacities for outbreak detection and response, though again, without any legal enforcement mechanisms or resources for poorer nations to achieve this. Okay, so here's a chart from that 2005 World Health Organization document that maps out the ideal spatial relation of global disease containment according to the revised health regulations. So as you can see, in this scenario, a given novel disease appears in a country through a form of global circulation, an airplane or a ship arriving at a point of entry, a POE here in the center. Each country in this vision is then able to use its public health core capacities to detect and respond to the event and to coordinate this response with the World Health Organization. In turn, WHO provides expertise in surveillance, risk assessment, and response coordination. So again, this is a sort of imaginary system of an ideal situation in which a successful global response to an outbreak would take place. For this system to work, of course, we need to have a method to ensure that each country has already adequately implemented its required core public health capacities. And so this is where we get to the checklist. How do we assess whether countries have these systems in place? Stepping back a second to the method of looking at checklists as the scaffolding of this apparatus. As DeGote and Sullivan have noted, that this seemingly banal list has a central place in a number of contemporary security practices. And they argue that these kinds of lists materialize the categories they purport to describe and enact novel forms of knowledge and jurisdiction. So the checklists that I'm going to describe here do this for a particular purpose: to generate knowledge about future needs in the space of global health concerning an event that might or might not actually occur. So again, turning to this 2005 document, the revised international health regulations, we can see here the early development of what I'm describing as a preparedness kit for global health security. Here, a brief checklist of necessary capacities each nation state should have in order for a successful global health response to an outbreak to occur. So these capacities are things like notification systems, control measures, sites of coordination of response. To achieve the capacities would require public health investment at the community, intermediate public health, and the national level. And they would have to be in place according to the regulations in all 193 World Health Organization member states. And the WHO developed a monitoring framework to check on whether each member state was actually fulfilling this obligation that they signed on to in 2005. And the framework was basically a questionnaire. And it turned out that the results were not good. Very few countries actually had these core capacities. They had initially been given until 2012 to fulfill these core capacity requirements under the international health regulations, but by that year, only 20% of WHO member states had actually implemented the requirements. A later report cited here pointed to weak political will and limited awareness of the regulations, as well as lack of resources as seemingly insurmountable challenges. The World Health Organization then extended the deadline to each country to 2016, but meanwhile began to investigate whether there might be other ways to galvanize resources and put pressure on national governments to build these core capacities, which were seen as crucial at the global scale to effective detection and response to a new outbreak. The 2014 Ebola epidemic provided the push to move more aggressively on this. WHO and the broader system of global health security, in particular the international health regulations, were harshly criticized in the aftermath of what was widely seen as a massively failed response to Ebola. The entire international community was blamed for allowing what was considered a preventable tragedy to unfold. Thousands in West Africa had died from a disease that had never before killed more than a few hundred people. And WHO, in particular, came under attack for its perceived failures in response. Some observers pointed to a failure of leadership in the organization, others to a lack of resources. But for my purposes here in this talk, what's interesting is that critics began to focus specifically on the international health regulations framework as a key source of the failed response, and two elements here came under scrutiny. First, the role of decision instruments that were meant to galvanize attention to a global health emergency. So the decision instrument here is the declaration of a public health emergency of international concern. And some of you may remember that this actually has again come up in the context of COVID-19, whether the World Health Organization was too slow in declaring a public health emergency of international concern. And we can return to this question in the conversation. But this instrument is designed to recognize that authorities around the world need to put their preparedness plans into action. And the second diagnosis was the long-running failure by member states to implement this core capacity requirement. And this in turn led to a renewed attempt to extend global health security across borders using elements of the kit that I was describing earlier. So as you can see, the event of Ebola was conceived as a kind of test, leading to a process of assessment and presumably self-rectification. However, it wasn't clear in 2006 and after whether WHO was by itself up to the task of improving the preparedness of the global health community for the next outbreak, given its failures in Ebola response. At this point, a new actor, remember this is under the Obama administration, 2016 in the United States. Just before 2016, between 2014 and 2016. The Global Health Security Agenda entered the picture. And the slogan here comes from an executive order from Obama in 2016, which laid out US responsibilities in the effort to ensure global health. It argued that United States preparedness for biological threat hinged on other nations' preparedness. The Obama administration pledged $1 billion to assist WHO in achieving the implementation of the IHR core capacities in poor countries. So this was actually the object of my inquiry at the end of the Obama administration. Now, of course, and we can talk more about this, this was completely defunded and dismantled under President Trump. So we're now going to be talking about a kind of virtual program that didn't really go forward. It was cast as a multi-country initiative, but the funding and organizational impetus for the Global Health Security Agenda came from the United States CDC, the Centers for Disease Control, which saw the WHO as ineffectual in getting countries that were seen as key sites of risk, that is, countries where an emerging disease that could threaten the US was going to come from, that the WHO was ineffectual in getting those countries to comply with their international health regulation obligations. But you can see that the effort of the global health security agenda is parallel to the core capacities requirements. But now there's a bit more funding, ostensibly, and publicity for the effort. It was an attempt by the US CDC to bypass what was seen as the bureaucratically hidebound and chronically underfunded World Health Organization. But again, defunded and dismantled under the Trump administration starting in 2017. So how did the imagined system work? As you can see in this world map, the role of the US was to convoke a set of partner countries to assist it in achieving measurable capabilities around the world. In this language of measurement and targets, we see the centrality of assessment to the sense of advancing a global condition of preparedness. You can see this as one kind of development project, a new kind of development project, but the kinds of public health capacities that are being supported here are distinct from those of classical public health, and I'll return to this point. Here's a diagram of the collaborative process that was designed for strengthening each country's capability for health security. The idea here is that if a given country, and the countries that the US had in mind here were the poor countries of the global South, if a given country is willing to participate in the assessment and develops a plan for capacity building, it will be eligible for funding and training support from partners, such as the US. What's called here a gap analysis will lead to action package targets. So there's a kind of development bureaucratic language here, and therefore a practice of critical self-rectification within each nation state according to the norms designed in this global package. And I'm coming to a close here soon. This is the measuring device that was developed by the Global Health Security Agenda in collaboration with World Health Organization to enable external monitoring teams to go in and evaluate each individual country's level of preparedness, its core capacities. In this schema, the assessment is to be conducted by a joint evaluation team, which consists of experts from member states, WHO, the World Organization for Animal Health, Interpol, and so on. The assessment works like this. There's a 5-day presentation within the public health, the national health ministry of a given country. It covers 19 technical areas. And after that, the joint evaluation team assigns scores for each country's core capacities. And countries are also encouraged in the system to hold simulation exercises as part of the assessment process. So just beginning to summarize, the key device here for producing knowledge about the condition of a given country's preparedness system is the indicator. An indicator is a device that is used, and here I'm quoting the historian Ted Porter, to point to something, such as the national economy or the health of the population, that cannot otherwise easily be grasped through direct measurement. So the indicator, in place of the thing of interest, the indicator measures something whose movements show a consistent relationship to that thing. The point is, a condition of preparedness is an abstraction. It's only through these metrics, through these devices, that you can actually try to measure something, the indicator. It's an elusive object of measurement, not least because it's assembled in anticipation of an event that has not yet arrived. But as Porter assures us, since the purpose of the indicator is merely to point to something as a guide to action, the ease of measurement is preferred to the meaning or depth, that is the substance of what is being measured. How does this measurement work? And I'll summarize this really quickly. This tool is actually about 100 pages long, the joint evaluation tool, and it's made up almost entirely of these kinds of checklists. These indicators, the one that I've got on this slide is a set of indicators that concerns a country's real-time disease surveillance capacity. And it's one of 19 different technical areas in the evaluation tool that are arranged according to 3 core categories of prevention, detection, and response. Along the horizontal axis is a checklist of the capabilities that will be needed in order to rapidly detect the onset of a novel and dangerous pathogen. And down the vertical axis is a color-coded scheme that enables a country actor to be graded according to its level of capacity. Here's one more of the 19 technical areas: the prevention of zoonotic diseases that move from animals to humans. So you need the right surveillance systems, you need an adequate workforce. This is the grading system, which moves from red, no capacity, to green, sustainable capacity. And so the conceit of this grading process is that it will lead to the formulation within each country of a plan to implement core capacity requirements, and especially with the financial assistance that's going to be provided by the Global Health Security Agenda, it will induce developing countries to comply with their international health regulation obligations. One last example of this checklist from the response category are two indicators of a country's preparedness. Does it have a response plan in place? Have risks and resources been mapped? So I'll stop describing this now. Let me just close with a final contrast between classical public health operating at the nation state level and this form of global health security that I've been describing. In discussions of why West African countries had been so vulnerable to Ebola, a common point of discussion was the lack of, oh wait, I may have, my screen is doing something. Let me make sure that I've got this going. Can you guys still see my screen okay?
Yes, we can.
Okay, sorry about that. So just closing. The common point of discussion was the lack of basic health infrastructure in the affected regions. And one might argue that the core capacities requirement in the international health regulations would address this deficiency in health infrastructure. But I actually think, and I think that COVID actually illustrates this well, I think that the requirement in IHR is much narrower and is actually focused on a very different set of functions than those of classical public health. So for the international health regulations, and you can see in the bottom right box what I'm alluding to here, the objects and techniques of public health infrastructure are going to be redefined. Core public health capacities refers not to prevention and treatment of common diseases in a national population, but rather to the detection and containment of outbreaks of novel pathogens that threaten to spread globally. These threats are emblematic of reflexive modernity in Beck's sense, and of a form of biopolitics that seeks to protect the functioning of critical systems from threats of interruption. And they are as much geared to protecting wealthy countries from the spread of infection over global circuits as they are to improving the health of national populations in poor countries. So just to end with a couple of thoughts on how we might think about borders and the global in the age of COVID-19. I think that an analytics of the global should or is very much helped by this sort of focus on the mundane artifacts that try to make things the same over space. But of course, the fact that technocrats in Atlanta and Geneva dream of this form of global surveillance and response does not mean that it will actually be achieved on the ground, as we are seeing now. However, it's important to understand the form of rationality that underlies these efforts with its own limits and possibilities. What I think we've seen in the COVID-19 response, and I'm alluding here back to the initial slide I showed in which the US and the UK were the most prepared countries in the world, is that apparent success in meeting these global health security measures does not necessarily indicate that one will be successful in managing the actual event when it arrives. So let me stop there, and I look forward to a discussion. See if I can stop showing my screen now. Yeah, great, thank you.
Excellent.
Did that work? Yeah.
Yeah, that works. And let me see if I can actually switch over to the discussion slide. Perfect. Okay. So now I'm on the discussion slide. I hope everybody was able to hear that well. Just as a reminder in terms of how this works, if you have a question, you can either basically, I think there is some form of a raise your hand function, or you send me a message in the chat. and then I am going to unmute you. But after I unmute you, you still have to click, if I'm not totally mistaken, on the microphone yourself to also unmute yourself. Otherwise, we're not going to be able to hear you. And then please just mute yourself. I trust you that you're not going to interrupt what goes on afterwards. And then obviously, I'm happy to ask lots of questions, but we'll start with you, obviously. And Casper, I believe you actually have the first question. So we'll start with you, and then we'll make our circle.
Thank you very much. Thank you very much for this really interesting talk, Andrew. I have a lot of questions, but I'll just stick to one, and maybe I'll get a second chance at some point. But it was just one thing that struck me was about sort of to think about it as the securitization of global health. That sort of when I think of the work that Randall Packard and others have done on global health, and they think about the time between the sense of time, and those who are sort of more into the social economic factors in global health, and then the more sort of biometrically focused things in global health. Whereas this seems to be that the time scale with this sort of more securitized sense of global health as a threat, that's something that's emerging, seems to be again sort of another set of ways of thinking about time in relation to health as a global concern. So just some reflections on sort of what this means for organizations like WHO, and the way that these, when it's securitized, what are the time frames? How do they change?
So, you know, I find the term securitization to be overly vague, and let me explain what I mean. I think it doesn't quite tell you what form of security is at stake, and so obviously biopolitics is a form of security, just in the sense of you know, there are risks that a population handles, and there are techniques for trying to mitigate those risks. I think that securitization, as it's used in international relations, not my field, refers more to the use of military metaphors or actual you know, diplomatic and military strategic rationalities to address what heretofore had been seen as other kinds of problems, like medical problems or problems of social welfare. I wouldn't call this militarization, really, this form of security. I mean, of course, in COVID, you're seeing lots of examples of militarization, but this form of security could be called a form of securitization, but you have to be very precise about what you mean. And I think in this case, it's about time, as you said. It's about trying to envision an event that is potentially catastrophic, but that has never yet occurred, and so you don't have an archive of historical incidents in order to do a cost-benefit analysis of the efficacy and of the economic rationale for certain policy measures in response to it, as opposed to other biopolitical problems. It focuses very much on vital systems, on infrastructures, on securing the functioning of those systems, and those can be national systems or international systems, the global supply chain, global food and systems, urban water systems. It's less, you know, the knowledge forms focus less on the population per se and more on the operation of those kinds of critical infrastructures. So I think it is a form of securitization, but that it but that you have to actually think about what type of security it is. Stephen Collier and I call this vital system security, and we distinguish it from classical forms of nation-state security or biopolitical security.
Jasper, do you have a follow-up to that?
Yeah, maybe I do. It's probably just the language that missed a bit. I wasn't sort of thinking specifically about securitization theory, but more sort of this sense that that you move into sort of a framework where it's like emergency response framework and so on. So it's sort of more this sort of perhaps the emergency aspects and the timing of an emergency, whereas a longer term, what is thinking as a sort of an unfolding catastrophe that's taking place that you would like to deal with globally. So it was sort of more just to clarify what I had.
Yeah, no, I completely agree with that, and I mean that the rationality is really built around acute, temporally confined response to a novel and unfolding event, rather than, as you say, chronic conditions. But what's sort of paradoxical is that in order for your future response to this imagined emergency to be successful, the discovery is that you do need to have some kind of core long-term capacities in place. But then it turns out that those capacities differ, at least according to the schema that I'm describing, differ from the kinds of capacities you would want to have in place to deal with regular ongoing diseases of everyday life, of which we all suffer from, and in many countries there are far from enough resources to deal with. One of the big controversies around global health security has consistently been the argument made by many public health practitioners that we have no rationale for spending a lot of money preparing for a virtual event, something that could occur, bird flu transmission, a biological attack, when in fact we need to spend all of our resources and more on the actual conditions that we have in the present. Cancer in the developed world, childhood diseases in the poor world. So that there's an ongoing tension between a form of rationality around health that's oriented toward actually existing long-term conditions, and one that is oriented toward the future emergency, as you said. And now there's a lot of hand-wringing that we weren't sufficiently prepared for this future emergency, which finally arrived.
All right, excellent. Then Holly Kariba, who's going to speak next week, actually has a question. I'm going to unmute you, and you're unmuted, Holly. But we can't hear you yet. I think you still have to click on the activate the microphone.
And can I just ask a favor for those who are coming on to ask questions, if you could quickly introduce yourself, just your name and where you're calling in from, and what your field is, just so I get to know you.
Yeah, we still can't hear you. It's if you in that control panel at the top, there is the microphone function. I think you have to click on that once. Okay, now it went to green. In theory, we should be able to hear you. Yeah, no, I can see you switch on and off the microphone, so that part I can see, but somehow I can't. Do you rather want to send me the question in the chat, and then I'll just ask it for you instead? Yeah, exactly. Okay, then I'll ask you something else in between, so Holly gets a chance to type this up. You mentioned that in 1851 there was the attempt to organize a system for global health management, and I just thought maybe you can elaborate a bit more on that for the historians in the room. That's fascinating. What's the context? Which was there conference? Who was there?
Yeah. Well, there are other folks who have written more extensively on this. Alexander White has a recent has a forthcoming book, actually, and he's at Hopkins, who has a history of this story, and others have written about it as well. I will just quickly summarize. There was a series of international conferences that were called International Sanitary Conferences initially in the 19th century that I believe were mainly assembled in response to the cholera outbreaks that, of course, were devastating, sporadic, and regular in the 19th century. And this was, before we knew how to treat cholera, and were linked to intensifying global trade, to shipping. And so a set of and countries would impose quarantines and trade restrictions when there was rumors of cholera outbreaks that might be on the way, that would have devastating trade consequences for those countries that had the outbreak. So the point of this initial set of regulations was to pick a set of diseases that were causing these economic disruptions, and get countries to agree that while they might put in place some quarantine measures, reasonable safety measures. They wouldn't completely close off international trade, so it's a kind of attempt to regulate the liberal system of trade in response to these novel outbreaks of disease. And as I said, it was limited to 3 diseases at the time, and the major event that I tracked much later in the 21st century was the expansion of the category of the kind of disease to which this could apply. So that there had been a regular, very sporadic revisions of these regulations up through the 20th century. But what the 2005 revision was considered a radical change because it expanded to the concept of emerging infections, and also put in place this notion of the public health emergency of international concern that would galvanize global coordinated response to such a disease. So I hope that helps, but it's just a little bit of detail about the 19th century story.
Yeah, and as you said, that's Alexander White is the author who's.
He has a forthcoming book, and also has written a dissertation on it.
Okay, I'm going to have a look for that.
I'm happy to send you the reference.
All right, fantastic. Thank you so much. All right, then we have Holly Karibo's question, which is, how does the global health security model envision the role between state agencies and private industry? Does this model assume that state actors will coordinate the response ultimately? How may failures in state leadership affect this dynamic in future approaches from your perspective? I guess that's in reference to failure in state leadership.
So this is a really interesting question and has been fraught over the history of this formation. And so let me just give you a couple of examples. I think it's actually one of the really important critical, analytical, and political questions to watch as drugs and potential vaccines are developed to respond to COVID-19. The global health security apparatus does envision, a system for the provision of biomedical countermeasures, whether those are drugs or vaccines. But of course, it relies on the private sector for the most part to produce those countermeasures. There's a really interesting debate around this in 2007 when this was during global anxiety around the possibility of a bird flu pandemic, when the Indonesian health minister refused to provide samples of bird flu from patients that had it in Indonesia. And Indonesia was one of the centers that was getting the most cases of bird flu. It refused to provide those samples to the World Health Organization, precisely to its system of surveillance, because the World Health Organization was trying to track mutations of the disease that might lead to human transmissibility, on the grounds that those samples were also being provided to a biotech company, an Australian biotech company that was patenting the sequences of the virus in order to produce a vaccine for it. And that in turn, that vaccine would not be affordable by countries like Indonesia. So they claimed what they called viral sovereignty over the disease itself, over the samples, and this created a stir. It actually forced the World Health Organization eventually to really think hard about how was it going to ensure fairness in the provision of an eventual vaccine for something like bird flu. That never quite got solved, but certain agreements were put in place so that countries that were providing data or samples on disease outbreaks would be, in principle, given a right to access at a discounted rate, some of these the drugs or vaccines that were produced. Now, with the swine flu outbreak in 2009, this really got put to the test in a different way, interestingly, in that there's a system of, and you're actually starting to see this now, the EU just ordered, I think from AstraZeneca, 400 million doses of coronavirus vaccine, which doesn't exist yet, but there's a system that are called advanced purchase agreements in which national health ministries can contract with a pharmaceutical company in advance of the development of vaccine to have the rights to those vaccines. And so at the very onset of the 2009 H1N1 outbreak, countries like France, Germany, the US, the UK contracted with drug companies to provide hundreds of millions of doses at billions of dollars of cost to their national populations, with the assumption that this could well be a very devastating influenza outbreak. Now, as it turned out, the vaccine had potential side effects. It was not exactly clear, and the outbreak itself turned out to be less devastating than initially feared. And so countries like France had a very low uptake of the vaccination program. Something like 10% of the population was willing to get vaccinated. And so there was a huge controversy in which critics accused the government and the World Health Organization of having raised the warning flags too early, of overreacting, of having conflicts of interest in their relationships with the vaccine developing companies. So there's been a fraught politics over the history of the assembly of this apparatus, and I think we're going to see this unfold in really complicated ways once a vaccine is under development. You know, who is going to have rights to access limited supplies of this vaccine? The wealthy countries are already putting their orders in.
And so I think the Gates Foundation, no?
Yeah, well, this is a little complicated, but yeah, the Gates Foundation is involved in a global vaccine development organization, and so it's an interesting question whether, you know, if the vaccine is developed, they still have to produce it, and will they be asking pharmaceutical companies to produce it? So I think there's right now we're in a global race for a vaccine. If it's developed by a nonprofit philanthropic agency, then of course the private sector would not be as involved, but there still will be this question of how you distribute globally initially limited supplies.
All right, Paul Nugent has a question. Paul, you're unmuted.
Great, thanks. Yeah, Paul Nugent from the University of Edinburgh, interested in African history and border studies more generally. So you can probably guess where I'm going to come from with this question, because it's a bit of the bee I have in my bonnet, but I still find it really curious that by its very definition, by its very nature, global health security implies that there is a health problem that is global, and yet country responses to the WHO are expected to come from countries. So it's very country specific, which the borders are inscribed in the very process of reporting. Is there never any real consideration of the possibility of pooling data, resources, future responses, or are the national silos that deeply entrenched?
Yeah, I mean, one of the criticisms that arose certainly in the wake of Ebola, and I think even more strongly now of the World Health Organization, is precisely its dependence on member states and its weakness as a multilateral organization in enforcing the international health regulations or in coordinating response, so that nation states don't become antagonistic with one another over the response. So as the WHO, as you say, is pretty weak. It depends on contributions from member states, and the US has been, as you know, using that against it, and has recently pulled out on the grounds that WHO is too complicit with China. Certainly there are critics who argue that there should be a much more global, really global system in which it doesn't depend on member nation states. But I think this is sort of the question with which I began the talk. I think the concept of the global has been proven to be one of potential, but still quite weak, both in terms of governmental structure and resources in the coronavirus event. In that all WHO can do is provide technical support, that is expertise, to those who want it and want to use it, but has no governing capacity. So I basically agree with the spirit of your question, but we're living in a moment when it looks like it looks very pessimistic for putting together that kind of serious global entity.
Thanks.
All right. I don't see anyone has a question at the moment. Casper, you said you have a list of questions. So yeah. Before I throw in another question, I'll let you throw in another question.
Yeah, so I guess this follows a bit from Paul's question as well. This was sort of the trajectory of thinking about these global emergencies coming from a Cold War context, and then that sort of makes, of course, total sense. But in that sense, it would seem that the kind of the Cold War context of the nuclear threat would be sort of more a north-north threat, whereas it seems that some of these things, at least from the Ebola and others, are seen as sort of a north-south conflict or sort of a relation as well. So just some, sort of reflection on the way that the global is construed and sort of has been construed in terms of these issues over time in your research.
Yeah. I mean that I think is a helpful question. Just it gives me a little bit of time to elaborate what the conceptual analytic project here is. And I guess I would draw on the term assemblage here, and I'll explain why. To say that it's not that you have a direct superposition of a Cold War system onto a global, onto a different global problem, but what you have is the taking up contingently of different elements from different places. And so you have a set of organizations whose task is to deal with world health, however you want to construe that, already constructed. So the World Health Organization, but also the Centers for Disease Control. A novel problem appears to those organizations, or is constructed in the late 1980s. This is the problem in the wake of AIDS, of emerging infectious disease. It's a different kind of problem than maternal child health, or of polio eradication, or smallpox eradication, or malaria, because it's a problem of dealing with events that have never occurred before and that might globally affect the functioning of societies and economies in a catastrophic way. So how do you deal with this problem? Well, what the proposal was to take up a set of tools that existed in a different domain, the domain of emergency management. Those tools are designed to address events that have not yet occurred, but that could be catastrophic. And those are these tools like ongoing monitoring and surveillance, coordination of response, detection systems. There's a whole bunch of things, and you can see all those tools, they existed and were invented, many of them in relationship to the nuclear threat in the Cold War. But then they could be taken up and redeployed. So the point is that a novel assemblage was put together over the course of a decade or so out of existing elements from different places. So it isn't that you have a direct application of the Cold War problem or of the Cold War response tools to world health, but rather a sort of contingent set of responses that congeal and consolidate into what I'm calling an apparatus. So that's kind of the conceptual framework, and it's laid out in this book that I mentioned, Unprepared, and the idea being to understand the sort of logic that's in play, and you have to actually do a genealogy of where the different elements came from and why they were assembled at a given moment.
Can I just a quick follow-up? So in making this assemblage, how would you say the role of the threat of terror would fit in? Sort of, that seems to be element from there.
The assemblage. No, the story, the way that I tell it, I think the story focuses at an initial stage very much in the United States, and it isn't that there aren't really significant actors also operating at the global scale in places like Geneva and the World Health Organization, but the proposal to use these tools to address global health problems, I think comes out of a U.S. biosecurity response system that's developed in the 1990s in response to the threat of bioterrorism. So you see, the very notion of biological preparedness was a post-Cold War response to the threat of the dissemination of bioweapons outside of the former Soviet Union into places like Iraq in the 1990s. There was a Soviet refugee or a Russian immigrant to the United States who had been in the Soviet bioweapons program, who scared U.S. biodefense specialists in the mid-1990s by describing the much underappreciated extent of the Soviet bioweapons problem, and the fact that the stocks of weaponized smallpox and anthrax had not been monitored after the collapse of the Soviet Union. So U.S. defense officials started to freak out that terrorist groups had gotten hold of stocks of weaponized smallpox. So some of the initial biopreparedness measures were trying things like inoculating first responders across the United States against a smallpox attack. Massively failed program in 2004. you know, and some of it in the ramp up to the Iraq War. So you're right that there's a sort of post-Cold War story about the threat of bioterrorism that's critical to the first stage of thinking about disease according to this logic of preparedness that then gets drawn in with SARS and the threat of bird flu, gets drawn into the global scale as a way of dealing with the novelly conceptualized threat of emerging pathogens.
Thank you very much.
All right, we have 2 questions, and we'll start with Vida. I'll just unmute you. You should be unmuted.
Yes, can you hear me?
Yes, we can.
Hello, so I'm Vida, and I'm from Maastricht University from the Netherlands. And I actually have 2 questions. So the first question would be around the discussion on the global health security agenda in general, because as you mentioned, there's kind of a discussion whether there should be a need to focus on something that is somewhere in the future rather than we should better invest in, let's say, healthcare capacity. But there's recently, this kind of securitization has been also used for different issues, for example, antimicrobial resistance. So it was at some point, especially from the UK side, they have been elevating this as a very important issue that which should be involved in the global security agenda, and which actually has been involved. So my question would be, like, what do you in general think, whether there's actually the need to broaden even more this health security agenda to issues like AMR, or it perhaps could threaten the whole idea of security, and then we cannot use it as a strategic tool anymore for example, infectious diseases that are very quickly spreading. And I don't know, perhaps another question, if maybe I'm going to tell both at once. Another one would be about the response of COVID-19 in Africa. So as we can see, it was, Africa has dealt much better than, for example, Europe. So what do you think, what we could relate that to? So that perhaps the resilience in African countries has really now raised as compared to the Western countries, and perhaps that the West should think about raising their awareness on emerging diseases as well, rather than just investing in different countries. So that would be 2 questions. Thank you.
So let me start with the first question around basically what threats should be incorporated into this vision of a future of global health security. And one of the things that I find really striking is that what I'll call the generic quality of the possible threats that are in the portfolio of events that global health security can address. So I think it actually was not at all difficult to incorporate, I shouldn't say not at all difficult, but one can certainly incorporate antimicrobial resistance as a potentially catastrophic threat. It doesn't have some of the qualities of the sort of urgent and sudden outbreak that we see with SARS or Ebola or COVID-19. But even something like climate change, one could make a case that this is a global health security threat. So I think that there's a real elasticity to the concept of the kind of emergency to which this set of tools should respond on the one hand. On the other hand, the tools that are available may not be the right tools for the job. I mean, antimicrobial resistance, you have to start looking at how to regulate industrial meat production. You have to look at to regulate how physicians are prescribing drugs. The antibiotics market. It's a whole different set of tools than what you deal with for thinking about anticipating an Ebola outbreak. So on the one hand, conceptually, it can incorporate these new threats, but when you actually get onto the ground of what kinds of capacities would you need to deal with them, they turn out to be quite heterogeneous. On the question of Africa and COVID-19 response, I actually would love to turn this over to anyone who's in the conversation to who knows more about this than I do. I haven't been following it that closely. I guess I'll say two things. One is that obviously this is a pandemic that is going around the world in unpredictable ways, and I don't think we yet know the story fully of what's going to happen in Africa, nor do we know the story of what's going to happen in the US for that matter. So I'm not sure the story is done. In other words, the way that you characterized it, African nations have responded better. I would just say maybe. Now then I would add to say, if that turns out to be the case, then it's really worth investigating why and how, and looking, for example, at these metrics that I was talking about in the talk, and explaining why it was that countries that scored very low according to these metrics turned out to be, as you say, more resilient to the actual event. So maybe I can pause if there's anybody who wants to jump in and say a word about what they know about this, and obviously including you, Vida, about the situation in Africa. I'd be very interested to hear.
Well, if I could follow up on that, so I actually think that there's something to learn for the West from developing countries. I mean, they've been dealing with that so much, and I think also, as we have seen now, that the way China has been responded, and the way this has not necessarily been picked up by some of the West countries, perhaps shows that we should learn on the action from each other a little bit more, because the China, actually, they were also been going through quite a couple of outbreaks, and they do know how to deal with that. And perhaps this international learning could be quite a lesson, actually.
Well, I think that's unfolding on the ground. I mean, so there's a lot of, actually the three of us were discussing before the panel started, the discussions around the quote Swedish model in the US, where there's been this debate over whether the approach in Sweden has been effective or whether we could learn from it in the US. Of course, the debate around whether we can learn from the Chinese model links into debates over authoritarianism and whether democratic countries are capable of the same kinds of responses that authoritarian countries are capable of. But then we turn to places like Taiwan and South Korea, i.e. the East Asian democracies that have clearly had a more successful response than the US. So there's no question that there's going to be a lot of learning and there's a need to look to different models. I wouldn't analogize the Chinese response to an African response. And I think, I don't know if we all know enough about the African response to assess it. I will say in terms of developing countries that, look at Brazil or look at Ecuador. There's a lot of really, really deeply problematic responses unfolding in Latin America right now. So I don't think we can be especially optimistic about those countries, and I don't really know yet whether we can be optimistic about what has happened in Africa or what will happen.
Yes, I fully agree. Excuse me, if I could just also follow up perhaps on the first question, just the last question. So just
one second, because we are still talking on the Africa question, and since we have an Africa expert here who spoke 5 weeks ago as well in the Colloquium series, Paul, do you want to throw in something on the situation in Africa?
Yeah, I mean, I've been following it quite closely, reasonably closely, and there is no such thing as the African response, or indeed a very clear pattern of what's going on. I mean, Ghana, for example, has been extremely assiduous in testing, producing weekly analyses of the results that are coming out. Tanzania denies that there is a problem, that they've solved it, that it's gone through the force of prayer. So you then are reduced to saying, well, the official statistics aren't terribly reliable. And insofar as the statistics are telling you anything, it's the countries which are better at collecting data are showing the worst results. So even in Ghana, if you look at the stats, it hasn't burnt itself out by any means. And in a country like Tanzania, where it's being denied, I really worry, and a lot of people worry, that this is like a major catastrophe looming. So I would be a little bit cautious about the Afro-optimistic view on this one.
Yeah.
Yeah, all right, thank you. Vida, you wanted to follow up on the first question.
Yes, thank you. So just a very, very broad question. Do you think that securitization of health could be further used as a strategic tool to lift up some issues on the political agenda, just like it's been done with AMR? Because if no one would have done this such a big issue as a, let's say, attaching the security word to it sometimes, it wouldn't have been elevated as much on the political agenda.
Yeah, I mean, I fall back on what I said earlier about I don't find the term securitization very analytically precise, but certainly if you know, calling it a national existential national threat is something that can you know, put resources toward treating disease, that seems like a strategy one might want to use. And indeed with AIDS, we saw that when the UN, you know, declared AIDS to be a, you know, global security, the UN Security Council declared AIDS to be a global security threat, which was the first time a disease had been officially put on the global security agenda. So you know, it's interesting looking at the US case again, that the National Security Council has been a site of interesting discussions around COVID-19, because that very global health security agenda talk I just gave, that tool was put under the in the offices of the National Security Council under the Obama administration. So the Obama administration was actually very interested in securitizing, as you say, infectious disease, making it an existential problem that you needed to have a special group of experts in the National Security Council attending to. Donald Trump's national security advisor, John Bolton, immediately, you know, defunded that, got rid of that office. He believed in good old-fashioned military threats as the things that we should be focused on. And then indeed, the very, what was called the playbook for responding to a novel pandemic that had been developed by this National Security Council office under Obama was tossed away, forgotten. And so as we saw, the Trump administration had no tools, had very few experts at the highest levels, nor tools for putting into place an adequate response, which is one major reason the U.S. has had this incredibly scattershot and failed really catastrophic response.
All right, then we have one more question from Stine Grumsen. You've sent me the question, like I can try to unmute you, but there is a attention marker next to your microphone. I don't know what that means, but you can try to ask the question. Yeah, we can hear you.
You can hear me, okay, thank you. Thanks for an interesting talk, Andrew. To me, it seems that emergency indicates this thing that something is acute, and often it is like this, that collaboration across the globe slows things down. And it seems to me that there's an issue about who gets to decide when and why something is an emergency or is considered a threat. And that affects how soon we as a global community is able to decide, because there's a question of trust in this. And often who and what we trust depends on a cultural context. So whenever something is a global issue, there will be a variation in what nations and what people from various cultural contexts trust what kind of organizations and what kind of sites of knowledge production. So the issue here is how will we ever be able to accept a declaration of emergency in time to prevent a disaster if we differ on the issue on who we trust to declare this, and how would we ever agree on what to perceive as a threat? I mean, most recently, Trump disagreed with the World Health Organization and spread mistrust. And so the question, I guess what I'm trying to aim at is a question about what the role of trust and trust in organizations in all this, and what the global community can do in order to increase trust in emergency declarations, basically.
Yeah, I mean, this is why I didn't spend a lot of time on it in this talk, but I'm very interested in this device that was invented as part of the global health security set of tools, which is called the Public Health Emergency of International Concern. And it's a device that basically is a decision tool for instructing national health authorities on when they have a potential emergency at hand. So it's a technical device that has certain criteria. It's easily spread, it's deadly, it might be one of these 7 conditions or a novel condition, and they have to report it immediately to the World Health Organization. The World Health Organization has a committee that's called the Emergency Committee, and it can be called into being. If it's called into being, then the Director General has declared this event an emergency. It happened with COVID-19 on January 30th, but as you're suggesting, that also then requires nation states to trust and adhere to that guideline. And in the U.S., the Trump administration kind of didn't take it that seriously. That the World Health Organization had declared an emergency on January 30th, 2020. So I think one lesson that we might learn, and I think this is what you're getting at in your question, is we need a trusted global organization that has a capacity to declare an emergency such that nation states will actually follow some of the technical guidelines and political recommendations that the global entity provides, and that WHO has not had the capacity to inspire that kind of trust, although it's the only agency that's a candidate. It's the only multilateral agency that's a candidate for it. So I think you could really make the case that we need to strengthen it. We need to figure out what went wrong, and try to figure out a way to rely on it more.
Excellent. I think at the moment nobody else has a question. In that case, since we're getting close to 8:30, or we are actually past 8:30 already, I thought maybe I can ask one very small question. Very small. So last 3 weeks ago, actually, Brian Buck kind of discussed how the border in southern Russia, which he describes as one of the first border regimes in general, emerged in the 17th century in the beginning as a reaction to a health emergency, and now you've mentioned this in 1851, and then of course the reactions which kind of come more recently from 2005 and so on. How do you see, and there's my very small question, how do you see the relationship between developing conceptions of sovereignty and global health?
Yeah, I had an instinct you were just pretending that it was going to be a small question. Well, in a way, I wanted to pose this question at the very outset. So thank you. What do we make of the global post COVID-19 or in the midst of COVID-19? And I think that both popularly and even among expert analysts, there has been a conception with the end of the Cold War and the bipolar power competition in the 1990s that we were moving toward something closer to global sovereignty, with the EU and ostensibly increasing power of multilateral organizations like WTO, maybe WHO. And we see here this sort of seeming collapse of that global model alongside and in complement with the global, the nationalist populist movements, whether it's Bolsonaro or Trump or other examples around the world. So, I think you could hope that potential emergencies like climate change or like pandemics are the kinds of events that can produce forms of collaborative global sovereignty. We're clearly not there. And so, I think we're just, I don't mean to dodge the question, but I think we just have to analyze how it's unfolding. I think the EU is a really interesting case right now because the EU project, which looked to be crumbling a little bit over the last 5 years, seems to be actually reassembling in certain respects in response to the economic aftermath and also the biomedical needs posed by COVID-19. So, that regional project may be strengthened, whereas and meanwhile, you might say that in the US, the nationalist separatist project of the right wing may have been weakened by this, and there may be room for a new cosmopolitan left to emerge. We don't know yet. That would be, a galvanizing force for a form of global sovereignty. So I think you're posing the right question, and we just have to, watch as things unfold over the next year.
Yeah, or years.
Or years, but I guess I just mean specifically with respect to the pandemic. Yeah,
okay.
Yeah. Or years, but you're right, or years. We don't know how long. Yeah.
And of course, the particularly in reference to your last point about the US, also the elections at the end of this year.
Yeah, it's going to be. We're all very anxious about, as you can imagine.
Yeah, which we too. I think it's not just the Americans are anxious about the American elections. This is something we share on.
Well, wish us luck.
We do. Casper, do you have anything else? Your microphone is off.
No, I think we have covered a lot of really important things, and thank you very much for this excellent talk, Andrew, and for filling us in on all of these sort of the background story to a lot of the things that are going on now, and that's at least the best starting point for thinking about what are we looking into in the year ahead, or maybe the years ahead. So I thought that was very inspiring, and learned a lot from all of that. So thank you very much for your time here, and thank you also to the attendees for joining us today. In next week, Holly Karibo will be speaking in the seminar. What do you have Holly's title on the top of your head?
Not at the top of my head, but it should be open somewhere. The title is From Curfews to Border Bans, Policing Juvenile Delinquency in the American Southwest. And the event on Facebook is already created. So if you go to the page of Colloquium, you can find the event there. And then, of course, you can also follow us on Twitter. I'm going to post about it on Twitter today. I didn't post about it before because I didn't want to confuse people. But so you can find it on Twitter. You can find it on Facebook, and follow us there if you're interested. Thank you.
Well, Moritz and Casper, thank you for the invitation, and also thanks to the audience for the questions and the conversation.
Yeah, thank you very much for being part of this.
Great.
Well, in that case, we wish you all a pleasant evening, and hope to see you next week.